This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everybody, to another episode of the Not Your Doc podcast. I'm your host, Vanessa, and we're here today with Seth, our producer, and Dr. Tadros, of course.
I'm waving.
Dr. Tadros, you have a special guest in store for us.
For all
Please
of us.
take it away.
Yeah. I'm sitting just to my left is Dr. Joseph Ojile. Dr. Ojile is actually a friend of mine, but more importantly, which doesn't qualify him for anything if he were just a friend of mine. More importantly, he's born and bred St. Louisan. He's a founder and CEO and medical director of the Clayton Sleep Institute here in St. Louis. They're actually moving, he was just telling me. He's a clinical professor of internal medicine at St. Louis University School of Medicine, where we both went to school for med school. He's board certified in pulmonary medicine, critical care, and sleep. And that's why we're here today, actually, for the last piece. We can pick his brain for anything he tells us, but we are especially interested in sleep today because of his broad interest in clinical medicine and in terms of patient care and in terms of also clinical research. He brings a lot to the table here. We could talk to a lot of people about sleep, but Joe is probably one of the best in St. Louis and probably one of the best in the country because he speaks locally, he speaks nationally, and he speaks internationally. He's past president. I think you finished your presidency in 2018.
Yes, that's correct.
For the NSF, the National Sleep Foundation, and you also sit on their board still.
No, I'm done now.
Oh, you're done.
Yeah. Mm-hmm.
Okay, they've released you.
Yeah, they expel you after so many years.
Oh, okay. There's a term limit. But thank you, Joe, for joining us. I really appreciate it. I think I've been talking you up to our team here, but also I think our listeners are going to really have great insight about a lot of stuff that's very common in our lives, which is sleep. It takes up at least a third of our life. In my case, probably half my life because I sleep in a lot. Joe, I'm going to start off. Is that all right?
That'd be great.
Joe, sleep seems to be highly conserved throughout evolution. Every creature seems to need sleep, or at least has a change in activity or metabolism on a daily schedule, a daily routine called a circadian rhythm, I believe. Joe, this is a three-parter.
Uh-oh, this is getting complicated, right?
Take notes. What is sleep? And what are the different ways that is studied in humans? And why is sleep so necessary for the preservation of life?
So, first of all, thanks for that overly generous introduction. You are my friend, and I'm proud of that. Thankful for that.
You've saved my tail more than a handful of times taking care of patients.
It's mutual. So sleep's really fascinating. I feel very fortunate to have stumbled into this field early in my training. And at St. Louis University, we had one of the early pioneers in sleep medicine. So I really do feel fortunate to be on the early wave of this as a specialty. So sleep from a biological perspective, interesting because every species we know needs some sleep. How different animals and species sleep is fascinating. For instance, some animals can sleep half their brain at a time, like birds when they fly.
Yes.
Certain marine animals, for instance, the ones we know most commonly are like porpoises, right? They can sleep one half of their brain at a time because why? They need to breathe and surface and all those sorts of things.
Protect themselves.
Down to the cellular level, there's evidence that at very early stages of life development, sleep is a requirement.
It's incredible.
It's really fascinating, and I wouldn't hold myself out as any sort of expert in biological systems in other creatures, but it is a really interesting thing to look at. As humans, sleep has been a valuable thing for us going back quite a ways in our development. And one of the things that has come up recently, which is interesting, is if you look back before electricity, a few hundred years ago, and now we teach patients this, believe it or not, is about first and second sleep. It's talked about in for instance, in Shakespeare. And so when they didn't have lights, people would, for whatever reason, they would go to bed rather early, get up. Some people even describe getting up and having a light family meal in the middle of the night. They'd have a little interaction, and they'd go back to bed and have their second sleep. It's not totally clear what all that was about. The records are somewhat sketchy, but it is well delineated.
Yeah.
So now we're using, that's called polyphasic sleep. So what we mostly do now is monophasic sleep because we can,
Yeah.
right?
Yeah.
We
So
have,
do you
we're
think
safe.
the polyphasic was just a necessity born out of the lack of light for longer periods of time in colder climates? Or okay, all right.
No, it's a great question,
Yeah.
and we don't know the answer fully to it, but it's
Yeah.
the right question. But what's interesting is that it tells us as 21st century people that what we do, just because we tend to sleep all at one time at night now, that isn't the only normal way to sleep.
Got it.
There are some people, for instance, as you have patients who, may work a night shift, and maybe they seek out help because they sleep for 4 hours, get up,
Right.
have to do life,
Right.
and then they have to get some extra sleep.
Right.
Because what we know you need is X amount of hours sleep per 24 hours. It's in our genetics. Most people about 7 hours and 40 minutes. But you can get that. You don't have to get it all at one time.
Oh.
And sometimes patients need some guidance and permission
Yeah.
to do that. You
Yeah.
know, so it's kind of a fun thing talking about evolutionary things. It's not that common of an issue. It's been studied in very specific things. Solo sailors in Europe, and the doctor who's the pioneer in that, Claudio Stampi's been to St. Louis for several times.
Cool.
And they teach them because they're by themselves.
Right.
They can sleep for 20 minutes at a time when they're in the open ocean. That's the safe. That's how far you
Wow.
can see.
Yeah.
But when they get down to the Arctic, they can only sleep for minutes or seconds because there's icebergs.
Right.
Yeah.
Right. So if you take that, there's no real valuable use of that skill.
Right.
The only thing is with maybe first responders. So our fellow citizens in this world, the Turkish folks, have a huge earthquake and disaster, and they're in Syria. They only have so many hours to save people, right? So that's an element. That's a place where polyphasic sleep could be used as first responders work 8, 10, 12 hours, get an hour sleep, get up and work, because they can do that for 3 or 4 days or people are going to die,
Right.
Yeah,
right?
absolutely.
So these are the thoughts where you might use various sleeping techniques in modern day.
Very cool. What an interesting extrapolation to hunting people out of earthquakes and other disasters. That's an interesting thought, because it is a limited number of people that you can have on the spot to fly people in, and everything else to help out it takes days and stuff. Yeah.
And you only have those
Yeah,
folks can
right.
only survive so many days in the
Right.
rubble,
Sure,
Right.
of course.
right?
There's a clock on it.
And as you
definitely.
well know, they had a second earthquake, which means even less people
Right.
are there to help them,
Right.
Right? Because now you can't get anybody in.
Right.
How sustainable is polyphasic sleep? Like if you're getting enough hours cumulatively, can you get enough REM cycles and quality sleep
So
in order to live like that for a long period of time?
so it's certainly not recommended,
Okay.
but only because we don't do it. There has not been any data to reveal that it's damaging when it's been studied. But there haven't been, to my knowledge, any long-term studies saying, can you live a lifestyle like this
Yeah.
permanently? I don't know that work's ever been done. The only adaptive work that's been looked at is, for instance, could you do it in the military?
Sure.
You know, for soldiers in the field, that
Yeah.
sort of thing. And the conclusions are there's nothing damaging to doing it
Okay.
for a period of time.
Sure.
But again, for a lifestyle,
Yeah.
I think that would be,
Not
I think it'd be a
recommended.
challenge to live like that.
Absolutely. Yeah.
Now, early motherhood could
Yes,
cause
exactly.
that.
Yeah,
As
I have a feeling some polyphasic sleep is in my future.
but maybe not enough total hours.
Right, exactly.
Well, the problem is young entrepreneurs. They'll rest when they die type of mentality. Go, and so that's an interesting concept we should pursue later for talking about all these young entrepreneurs who have energy and want to get a lot of things done. And Elon Musk says, if I work, a few more hours than you, by the end of the year, I've worked so many hundreds of hours more than everybody else, and that's why I'm successful. But anyway, cool. Vanessa, we're gonna alternate. We're gonna ping pong. We're gonna tennis racket this back and forth.
Absolutely. So, I mean, you went ahead and alluded to this already. Obviously, I'm expecting my first child in May in a few short weeks here. So,
Yahoo. Can
you talk to me about how sleep affects expecting moms? I don't know if that's a huge area that you've explored, but why is another growing human being inside me messing with my sleep so much? is he stealing half of my sleep from me because we only have so much to go between the two of us? Like, what's going on there?
So first of all, congratulations.
Thank you very much.
It's a blessing, and it's a great thing for you,
It is.
and it's
It is
exciting.
exciting.
So let's kind of break it down into a couple different areas. First of all, pregnant women are wonderful and beautiful, and you are both. And so when you when you start to look at pregnant ladies, there's the ladies can have a couple issues. One, if snoring may have been an issue before they were pregnant, you have increased blood flow to the sinuses and the posterior pharynx with pregnancy. And so some ladies, when they get pregnant and as their pregnancy progresses, may develop heavy snoring or obstructive sleep apnea,
Wow.
which there is data to indicate that can be an impairment for the baby based on the scores when they're born, right? So they're APGARs.
Yep.
So that's one thing to think about when we talk about pregnant women. It's something that actually we have a bit of passion about because it is a suggestion that it could be to cause risk for preeclampsia and, of course, other maternal fetal complications. And so when you think about it's a low risk, but it's a high acuity. If there's a complication with a baby or a mother, despite the devastation to these young people, it's also always a big problem from the standpoint of resource utilization, damage to their family, and then the horror of a young woman or a baby being injured. So we have that issue. The other issue is that also women develop when they're pregnant a significant, frequently restless leg syndrome, which can be quite disruptive to sleep, and you can't use most of the normal therapies. So you're left with some of the more common but maybe less effective things like rubbing your legs and warm baths. I think you are going to see some introduction, potentially some other non-pharmacologic therapies, and we may be able to talk about that in a future discussion, but they're quite interesting. And so that could be of benefit to ladies that are pregnant in the future, depending on what the FDA says. Then you have the issues of just the discomfort and the issue of body position. So as the pregnancy, especially you get to the level where you are now, it's quite uncomfortable to sleep in certain body positions, and then sometimes not even prescribed by your OB, right? They don't want you to sleep on your back, for instance, at a certain point for a variety of reasons. All those will add to the difficulty of both sleep disruption and insomnia. And then lastly, you just get the difficulty sometimes, even though you want to go to sleep, you can't get to sleep. Right? You develop symptoms of insomnia, or if you had insomnia before sleep, that can be an issue. And as you well know, most of the medications that we use for especially sleep, they're not evaluated significantly in pregnant women. So that's on the pre-birth side,
right? And then things get really fun.
Then let the fun begin, right? So now you have to deal with both a baby and the mom,
right?
So the mother's recovering from her delivery and has the joy of having that baby, but the baby, especially these first few months, is quite dependent on mom, aka needy, and waking mother up for feeding one way or the other. Frequently those first few weeks hourly or every other hour.
Right.
And so however those resources to get that feeding done, whether it's a team effort or whether mom's doing it, it is quite disruptive. And so there's just no way around the sleep deprivation.
Right.
And so part of that for most families or for physicians who are involved in those families is to try to encourage them to have resources to get a little bit more sleep, even if it's not optimal. Baby sleep and infant and children's sleep is a whole nother can of worms, probably beyond our scope today, except that I think there's a few interesting developments since Dr. Tadros and I had our children, and a couple of those I would mention, learning from my colleagues. One, now they have the Back to Sleep program, right? Which is new since our children were little.
I don't know anything about it.
So they want children, and we used to put our children to bed on their tummies. Now it's back sleeping.
Every few changes, then stomach side back, back,
and that's the SIDS prevention issue. It's a fascinating issue. Now, again, no expert in it, but I can give you some references offline, which is really interesting. The other thing that happens now are the sleep sacks, which are rather interesting because blankets were determined to be problematic.
Right.
Really?
Yeah, right. Yeah, I know. So they
Again, a risk for suffocation.
Really? All the knit blankets from grandma?
so now they have these little, and actually they're quite interesting.
Yeah, they're amazing.
Yeah,
actually.
so they have little arm holes, and they're basically a zip-up blanket around their bodies with
Okay.
armholes.
All right.
And it serves several purposes.
Yeah.
One, the tactile.
Yeah.
We realize we need something tactile, right?
Right.
To the point where in the space station, as you know, they, even though they're weightless, they have basically sleeping bags that they can zip into, so they have a tactile feeling. So
Right.
it gives the babies tactile touch.
Right.
It's a signal to them. It's bedtime.
It's time to go sleep,
Right?
right?
So you get them in their sleep sack, they know it's time, right?
Sure.
So that's a new development in the last 10 years or so. And those are probably the biggest. And then the awareness that young parents have, much more than certainly I did as a young parent. And my
don't-
friend here, Chuck, probably knew everything. But,
No, I didn't know anything.
But that the successful navigation of routine.
Yeah.
Young parents, in our experience, mine and our families, my wife's, much more structured about bedtime, wake time, naps.
Right.
I mean, we kind of look at each other, and our kids sort of went to bed around the same time.
Yeah.
Kind of got up at a certain
Right.
time, and they got their naps sort of at the same time. So in any case, I think all those elements, childhood sleep performance are been much improved.
Yeah.
And there's more to it, of course, than that. Letting the children cry and get in the routine of putting themselves to sleep.
Right.
Very difficult things to execute on, easy to talk about.
Right. Well, it's interesting that you point out, maybe with you and Dr. Tadros, when your kids are coming up, that some of these structural elements were like not a big part of the experience.
Right.
I feel like my generation is the pendulum swung all the way to the opposite
Yep.
side, where we want to be hyper regimented about everything.
Right.
And if we can't get those things, our kids' sleep and eating patterns and cycles and stuff into a regimen, that something must be wrong.
There won't be.
And so I'm
They'll
taking comfort hearing you say that the all different types of sleep patterns can work. That it's our bodies are built to adapt and be resilient through these natural stages of life. So I think that's great.
That is always a problem, that you feel like you're an A minus. You want to be an A plus parent at all times. You never want to be even an A minus. I'm glad. Talking about this, so what's sleep hygiene? I've talked about it to my patients, and I know oral hygiene. My daughter's a pediatric dentist, and hand hygiene. So what's sleep hygiene, and why is it so important, and why am I always bad about it myself, as I woke up at 3:30 this morning?
And looked at your phone right away, right?
Looked at my phone.
So
You're going to kill the sleep expert.
we have a chest pain over here. So sleep hygiene. I'm actually glad you asked the question, because nobody ever asks.
Oh, of course.
So
They should.
yeah,
Of
because
course
they want to
do.
go right away to having a sleep disorder. And sleep hygiene is really probably the most basic and important thing to do. A couple things. One, our brains want routine.
Yeah.
They like routine. Two, if you start to think about it as a structure or as performance, it's doing the things that our brain. We like to say, what I tell patients, what your grandma told you when you were little was right.
Yes, I tell people that all the time.
Yes, they knew.
It is. It's true.
Go to bed at
unfortunately,
the same time.
Yep.
Get up at the same time. The other thing that the old timers knew, we're old timers now, by the way,
Yeah, we are.
is getting
Yeah.
bright light in the morning. Probably
Yeah.
one of the least appreciated things that keeps your body's internal clock, your circadian rhythm, and it also so by 20 minutes. 30 minutes of bright light when you get up at your fixed wake time. That'll help keep you centered. It helps your brain know, believe it or not, when you should go to bed. So that bright
That's a very
light's
important
important.
part.
It really is important. So and what we have now that we didn't have was not just the sun, but you can actually use either light.
Right.
They have light boxes.
Oh, yeah.
There's a interesting development. They have light visors, but there's also an interesting technology that just got released, and we're bringing it to St. Louis. It's called AYO, and they have an app, and it's a circadian rhythm app, and then it has it looks like just the rim of the top of your glasses, and you don't have to buy that, but if you do, the app will sync your light delivery with that, so you can wear it. And it's structured such that it shouldn't
Sunshine.
disrupt you.
Yeah. It's from above. Is it from above or
Well,
anything like that?
and the
So-
type of light, and it'll
Okay.
just give you
Right.
enough light,
Right.
but it won't disrupt you if you're
Right.
doing other things. So But you can also use a computer desktop or a laptop to get the proper amount of lux of light, measurement of light intensity. iPads don't really work. Phones don't work for this task. But if it's a dark, like today, rainy day, you could do I use the term read your newspaper. Nobody gets newspapers, but you could read your newspaper on your computer, laptop, or desktop and do that for 30 minutes. And that's enough light to keep your circadian rhythm centered. So that's the beginning of sleep hygiene. Frequently, that's interventions.
That's actually for seasonal affective disorder.
Yes.
I tell people 10,000 lux, 30 minutes in the morning, just like you said.
Yeah.
Specific broad spectrum, white light, blah blah blah.
That works.
Just like, it works. It's a big deal.
That was one of the first non-pharmacological things that I tried in treating with my own mental illness stuff. Was getting a therapy light, and they've shifted from it like a giant box that had fluorescent lights in it to something much smaller. It looks like a desk lamp now, and it hits at just the right angle. It's beautiful, nice diffuse light, but it really helps. I agree.
And these things are getting better, right?
Yes.
Let's just the other things to think about are, of course, the things you already know. You should stop drinking caffeine. After we tell people sort of afternoon, but some people, if they're sensitive to caffeine, may have to stop sooner. Some sort of exercise during the day. Food, frequently asked question, low on sugars, a lighter snack at bedtime, more based on protein. That can be a factor. The typical things of temperature.
Yes.
Go to bed at, have the temperature for most people cooler. Rather than warmer. A blanket's helpful. Now I wouldn't say this is part of sleep hygiene, but weighted blankets in adults now are very common for some people.
It's a big deal for us. We're dealing with a lot of people with anxiety issues and stuff.
So for anxiety perspective, the weighted blanket helps.
Yes. Oh yeah.
Isn't that interesting? That's not something I would see particularly.
No, it's I've listened to some of your talks about tactile sensation for socks on the feet. So all these things actually matter. Hat on the head at night, the sleep cap or sleep hat, like Christmas time and stuff like that. But all those tactile things make a difference for select people, not everybody.
It's the same idea as swaddling a baby, the sleep sack that we're talking about, kind of that comfort mechanism.
So those are the big, I'm trying to think if there's any other big ones. And then lastly, since it sounds like that may be an issue in the room, when stopping electronics an hour or more before bedtime. And if you get up during the night, some people do. As you know, every 90 minutes we come to awake. We wake about every 90 minutes for normal sleep. What's abnormal is if you can't go back to sleep. So what we tell folks is, if you can't go back to sleep in about 5 or 10 minutes, get out of bed, keep the room dim. Don't, under any circumstance, get your phone out or computer. If you, preferably, we don't even want it in the room. Do something dull. You can meditate, pray, read a book that's dull. When our patients teach us so much, as you well know, there's a free website. I think it might be an app, but certainly a website called Boring Books for Sleep, which is somebody reading
monotone.
Yeah, but off copyright books from the 18 and 1900s. And they
old English.
Yeah, they just read them to you. And they're done it, and they're not offensive. They just kind of read them. And it works, by the way. So
bores you back to sleep. I love it.
So Boring Books for Sleep. And it's free, so, and then once you get sleepy and tired, get back in bed. So it works both to prevent something from happening, and if you're doing this now, it'll help start over a period of several days to a week or more, extinguish that behavior. So you can't, once your brain gets turned on to waking up, especially to check emails, it only takes even one night.
Right. That's right.
I mean, we get people, I'm sure you had them, that get up to smoke during the night.
That's right.
And nicotine's highly stimulating.
Well, I used to get up because for my prostate, for my nocturnal, and then I'd check my phone. And of course, before, if you just went to the bathroom, you can go back and go to bed. But now the phone, and now there's something there all the time. So yes, but now I'm relaxed. I'm not panicked like a lot of people. So which is its own advantage. Well, good.
Well, I think that's an interesting segue. And you were, Dr. Ojile, you were thanking Dr. Tadros for even asking about this, because a lot of times people want to skip right away to, insomnias and parasomnias and disorders. We actually love on this podcast to talk about all of the behavioral things that matter in taking care of our health. So that I'm glad we started with that.
Mm-hmm.
Now, can you talk to us about different types of insomnias and parasomnias where people really are starting to develop some sort of sleeping disorder?
First define, just because not everybody knows what an insomnia is,
Yeah,
and a
please,
parasomnia,
yes.
because,
So let's talk. That's great. So insomnia is defined as difficulty getting or staying to sleep with a daytime consequence.
Okay.
So
Okay.
some people, they can have some challenges or some nights they can't get to sleep, but they wake up and they're functioning fine the next day.
Sure.
Or they just don't need as much sleep. As we know, about 1% of people they're fine genetically on 6 hours of sleep or less.
Yep.
So they're what we call short sleepers.
Yep.
They're just not short people. So that's, but that's only 1%. So if you think of all the people who tell you they only need to have 6 hours sleep,
Right.
I'm going to gander that it's
over
more than
1%, right?
So,
yeah.
but if you don't have a daytime consequence, so if you have a daytime consequence, that's the definition, and typically for more than 3 months. So once you go from there, the most common things we look at, certainly what's the most common issue, which what you deal with frequently is stress and anxiety.
Yes.
It's the number one thing. If you look at the NIH consensus conference from about 10 years ago, 2/3 of people had stress-related issues. So part of it is getting people to figure out some methodologies of how to deal with that.
Yes.
So our initial approach, if that's the complaint, is to begin to define what the issues are. So we have people, just like we have people who want to lose weight, do a food diary, have people do a sleep diary. So they chart for us when they go to bed, when they get up, how many awakenings they have. We have a very simple tool, a piece of paper they fill in the blanks for about a month. And then we look at that and we start to come up with an individualized plan for what might help change their behaviors. So I'll just share with you some of the more common things. What we do tell folks is this is a process. The process does require work. It's optional. We're still living in America. You don't have to do this, right? So we want to give people the ability to choose to do this. We want them to choose sleep as an option. And we tell them it may take 3 to 6 sessions to get there.
Yep.
Okay? So what are some of the things that we come out initially in these sleep diaries, which are kind of interesting, I think, maybe for your listeners to know. The biggest things are what we alluded to on the sleep hygiene, widely varied bedtime and wake time. And
absolutely.
so that is really a big thing.
Yeah.
And for a variety of reasons.
Yeah.
One, people,
family.
they're family, they have little children or elderly parents now that they're caring for.
Right.
Or they just don't want to go to bed at the same time, right? So we have to find out from them, is this actually a problem for you? And are you willing to do something about it? Because it's optional, right? They don't have to do anything. So one, that's one of the bigger issues. Believe it or not, the second biggest issue, we'll say 1 and 1A is electronics. So we've already talked about that. But 2 is people spending too much time in bed.
Very interesting.
So what we like to share with patients is...
So it becomes a negative association almost, right?
Well, their sleep becomes inefficient, right?
Okay.
So if you think about, especially in America, we're a very outcome-driven society, right?
Sure.
So if you start to play a sport, how do you become better at the sport?
Just do it over and over
Practice.
again.
You practice it, right? So sleep is the one activity that if you practice it, you get worse, right?
Wow.
So by laying in bed for long periods of time, your sleep becomes very inefficient. And so the brain looks at the bed as the place they rest, not the place you sleep. So ironically, what we do is once we see what their sleep timing is like, we will narrow down their time in bed. There is actually an intervention, which is a little more than this, which is called sleep restriction, which we do under careful circumstances.
Sure.
But what I'm talking about, we can do very easily with many people. So it's one of the 2 or 3 most common things we see, which are in effect unexpected by the patient when they do these sleep diaries.
Yeah.
Right.
So stable wake time, bedtime, bright light in the morning, getting rid of electronics, and then this narrowing of the total sleep time, but still giving them enough time to be rested.
Right.
And what you do is you end up making their sleep, once they narrow their sleep time, their sleep becomes much more dense.
Right.
You should sleep about 9 to 9.2 minutes out of every 10.
Okay.
So when you see people that are lying around in bed that are in bed for 10 hours, but they're only sleeping 7, Okay, you'll start to see that, and it only gets worse.
Right.
So they'll go to bed even earlier.
Right.
So we had an individual this week who's complaining they're going to bed at 9 and upset that they can't stay asleep till 6.
Okay.
Yeah, or 7.
Yeah.
And said, well, I could really go to bed at 8. Like, okay, we're going to do the opposite. And here's why. Now, they may have another disorder called advanced sleep phase, and we'll talk about that in a second. But so those are some of the more common things we do. Getting rid of stimulants such as caffeine, nicotine, right? They're big.
Yep.
Cigarettes is a sidebar, are really an issue for some folks with sleep. Nicotine is the only substance that gives you insomnia when you use it and when you withdraw from it.
Yeah.
So when people withdraw from cigarettes, one of the most common times they have recidivism, they start smoking, is at night.
Yep.
Right.
Because they're having insomnia. So we want to be really sensitive to that issue and try to give them some alternatives there. Okay, so that's that insomnia piece.
Yep. How about parasomnia?
Parasomnia, I'm sure, is several textbooks worth.
But we'll just give you the Cliff Note version.
Yeah,
Of course, they don't use Cliff Notes anymore,
Yeah,
right?
well.
We're dating ourselves.
Flashcards. My version's flashcards. But anyway,
Cliff must be going away.
Right. No, they're still there. They're still there.
So
Now
parasomnia.
we have Chat GPT.
Yes.
Yes.
No, chat.
Spark Notes.
Yeah.
That's
Spark.
So parasomnias are, we call those things that go bump in the night. Okay, so they're abnormal behaviors at night. There is a variety of them, but what most of them involve is that you're having a behavior asleep while you're asleep that is abnormal. So what are those? What does that kind of vague description mean? The most common talked about things, right? We think things like sleepwalking and night terrors, but the most common disorder that we treat, interestingly, is when people start acting out their dreams. So, and the most common of those is called REM behavior disorder.
Wow.
And that occurs typically 6th, 7th, and 8th decade, a little more common in men than women. And the classic case now, it's a little bit less because the World War II generation is about off the scene, but it's a older gentleman who was in, quote, the war, and they start thinking they're in a firefight and swinging in their arms and maybe hit their spouse.
They do hit their spouse, yeah.
And they don't mean to. Right?
No.
It's a horrifying thing.
Sleep.
So it's easily treated, but that's the most common parasomnia. So any of those nocturnal behaviors or sleep-related behaviors when the patients are unaware, those are parasomnias.
Wow.
And I had a daughter that's, my wife used to talk in her sleep whenever she was much younger than before I met her. My daughter has it, so sleep talking, and And are these accentuated by sleep medicines sometimes, like Ambiens of the world and stuff like that?
Yeah, that's such an interesting question. So some of these behaviors are accentuated by stress, sleep deprivation, and sometimes by alcohol. They're classically called priming substances. It can happen. You said by, but your question wasn't.
Yeah, about Ambien.
Ambien. So the drugs.
Yeah.
So
the drugs make them worse.
Yeah, some of the drugs can cause abnormal behaviors, especially when used in higher doses than prescribed.
Okay.
Can do it in people that aren't even don't even have that.
That's right. They don't have.
So effectively, what happens is that if the person, when they wake up, if the levels of the drug are elevated,
still high.
So those drugs, of course, used carefully in the correct doses, you don't see these behaviors very often. But we always want to caution folks that this can happen because you are taking a drug, and drugs do have side effects.
Well, that leads to my next question. Somehow we're hitting 1,000 here. We're batting 1,000. Joe, I've written many prescriptions to help people get to sleep and stay asleep. I've also helped on the other end. I've also written prescriptions to help people stay awake. So what are our brain's sleep and wake circuits, and why am I having such a hard time with getting it regulated for my patients?
So we're learning more. It's really a very fascinating question, and it has to do with current drug development. So even advertising that you're seeing today has to do with different ways we're looking at the sleep-wake cycle and also the sleep-wake wiring. So we used to sort of look at medicines to sedate you and then medicines to wake you for some people who we call disorders of wakefulness.
Right, yes.
And so now we know that there's circuits that help your brain sleep, but also there's circuits that we can modulate which are shutting off circuits that help you wake up. It's a different approach, right?
So we can improve the sleepiness circuits, and we can shut down the wakefulness circuits
exactly
to help you sleep.
To help you sleep.
Right.
Now, what's really doubly interesting for me personally about your question is that we are agnostic about medicine. We're not anti-medicine.
Okay.
We're agnostic. And for most patients, medicine should be considered after we do all the things that you both brilliantly brought up before that question, which is all the sleep behaviors, making sure they're tight, doing all those things. And if people are stress management, if you start to incorporate this holistic approach,
Right.
most patients actually don't need medicine.
What you've said, which always catches me, is that sleep is not right at bedtime. It starts at the beginning of the day. Whenever you wake up, the light, your stress, your caffeine, all this stuff, sleep at night starts 12, 14 hours before, which is a big deal. I don't think most doctors think that way, and I don't think most patients think that way. That's for sure.
Well, and that's part of our.
And you have an insomnia section within your.
Yes, we do.
Yeah,
we have
yeah.
it. I mean, we say, and I think it's probably still true, we have the only freestanding insomnia center in the country.
Yeah.
But one of our passions is to bring the best of sleep medicine to St. Louis, and part of that involves sort of this educational piece.
Yes.
And we know, I always tell people, we know when we're winning. To your very point, when people get up in the morning and they'll tell us something that's very important. They'll go like, I'm not worried about going to sleep now when I get up in the morning. And that kind of gives you a window into their level of anxiety, that when they get up in the morning, they're already stressing over that night.
I've been there before, and you're literally in tears as soon as you get up because you want to be back in bed before you even leave bed.
Yeah.
They're literally tearing up because they're so exhausted.
And they're anxious then. And
It's just terrible. The rest of the days could be atrocious for them. Yeah.
And one other adage about sleep, which is quite true and why relaxation can be very helpful, is that sleep is like sex for a man. If you think about it, you can't do it. So when people are going to bed, if they're saying I've got to put myself done, you cannot do it.
Right.
So one technique besides regular relaxation, a technique that Dr. Mark Muehlbach's our PhD and we've worked on with our folks, is we call it a worry journal. And so we have people, it sounds silly, but it's so effective.
Yeah, I'd be writing on the back of the journal.
But you write it down
the spine.
Yeah,
right.
And what's the theory, right?
Right, sure.
It's an old theory, as old as the
is.
Bible.
Yeah.
And what is the theory? A burden shared is a burden given.
Yeah.
So what we're instructing people is we're not advocating whether they journal or not. Okay, they can. It doesn't matter what they do with my view, and this is a anecdotal view, not necessarily a scientific view, but the act of writing appears to be important.
Absolutely.
So we tell them we don't want you typing it on an iPad or a phone.
Yeah.
You have to get a piece of
Mechanics.
paper and you have to write it, and it can just whatever your worries are, or even a to-do list for the next day.
Sure.
Just the act of writing it,
Right.
and then you can leave it. Now you're leaving your burdens to that paper, right?
Absolutely.
It's amazing if you do the other things. This is an adjunct to all the other things we
Right,
talked
it's
about.
additive, right.
But if you do those things, and the next day, if you want to journal, you can.
Right.
But otherwise, you can just burn it or throw it away.
Joe, I just was texting one of my friends who's a licensed professional counselor, and I asked her, I said, blah, 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 why does it feel better to unload on somebody? And she says, well, sometimes if I'm angry, I write it down, but I never send it. And just the exact same thing. And it's the mechanics of writing it, and you don't have to send it, you don't have to do anything with it, but it's exactly the same principle for therapeutic, for depression, anxiety, the same thing that you just described. Exact same process.
It'd be interesting to know from some of our neuro colleagues, right?
Yeah, right.
Is there a neuron discharge? Is there
I don't know.
something that happens?
Right.
But it's clearly effective.
Yeah, there's there for a lot of people. Yeah.
I'm struck here by all of the overlaps that I'm hearing with treatment of mental health as well as sleep. I mean, almost all of these are the same sorts of techniques that we're encouraging patients to pick up that I've had to pick up throughout my life.
Yep.
And, it just kind of drives it home that some of these most entrenched medical issues that we deal with are so much about reframing our thinking, getting tools to help us manage the symptoms, the way that they bother us and weigh us down throughout life. And it's great to hear that sleep can be included in that category, that it's something that can be managed by, thinking about it well, by discharging our stresses, by,
Well,
managing
I
those
mean,
things?
they talk about the vital signs and pain being a vital sign, but I think I use sleep as a canary in coal mine for my bipolars, for
Oh
my
my God, yeah.
for my chronic pain. I mean, that's the stuff that leads sometimes for weeks to months before they come see me or their family says enough. We have enough of your depression, but it shows up in their sleep wake and their sleep energy relationships, before, and then they come see people like us at the ketamine
Well, to
clinic.
show how smart you are about that.
No.
And if you look at post-traumatic stress,
Right, right.
and also the chronic brain injury,
Yes, the
stuff with
CBIs.
So, the NFL had famously, and of course it's out there, right? But most of those folks, their first symptoms were insomnia.
Right. Yeah.
And so that it is, in a sense, that canary in the coal mine, right? So
right.
I think it's smart to look at.
What we're going towards in mental health is finding a way not to have asked patients how depressed in the scale and try to semi-quantify, to look at people's, whether they're EEGs, their sleep-wake cycles, their fMRIs, and we're looking for ways to try to find how to diagnose people without having to, just like looking at blood pressure. I don't have to ask you about your blood pressure, cholesterol. So this is interesting stuff whenever we can look at it from sleep.
And I think one last thing, I think to your point, we're really fortunate in St. Louis to have some very fine psychiatrists and mental health professionals. And one of the things that's important to us as an organization is to collaborate. Make sure they know we want to collaborate with them.
Yes.
The patients and the doctors are often shocked that we call them.
Yeah.
Uh-huh.
It's like, look,
Good.
we need to make sure we're in line. The other thing is, for most patients, I think it's best for their psychiatrist to write all their drugs. And it's just actually a tactical issue.
Right,
it
When
is.
one person, psychiatrists by and large are highly trained in pharmacology.
absolutely.
And again, I think we're very fortunate in town to have some very good people. And so let's coordinate with them, but keep one person in charge, work together with making the patients
Always.
better. I think that collaborative approach is very helpful.
Yeah, as a primary care physician, we only one guy or gal to take care of your pain medicine, your mental health medicine, oftentimes the same person. Big deal in terms of absolutely about covering, making sure you don't mess with the patient in unintended ways. Speaking about medicines, Joe, every time that I wrote for sleep medicine, I let out a deep groan inside. It just killed me because if the medicine worked, the patient wanted to stay on it ad infinitum forever, and if it didn't work, I'd be hearing about it in a couple of days. So I was stuck. No matter I knew what was coming. One way or the other, I was not going to be happy. And so what is non-restorative sleep, and what was I doing wrong, and why is it that I needed to talk to people more about physical exercise, sleep hygiene, caffeine, and behavioral modification, CBT, cognitive behavioral therapy?
So let's just, first of all, you weren't doing anything wrong, as per usual. The one thing about sleep, if they have these if people have chronic pain,
Right.
if they have psychiatric disease that's flaring,
Right.
The medicine's not going to overcome the pain. So getting the underlying problem addressed before you consider the sleep medicine. Addressing the sleep behaviors before we do the sleep medicine.
Yeah.
Well, now your number of patients who get medicine are rather dramatically reduced, but also just like tilling the field,
Right.
you've tilled the ground,
Right.
and the brain and the body are now ready
Right.
for the medicine to be used in the way it was designed.
Gotcha.
And so that really improves the success of the medication, but it's part of a total sleep program.
Right.
And so in that way, then the patient's ready for it. And if they need it, because they do have primary underlying insomnia, it's okay. But by the time you get to this point, you've now gotten the right group of patients who do need the medication.
Right.
And then if it's effective, the minimum dose for effectiveness
Right.
you're able to use that. And then if they need the medicine because they have that biology, that's okay. There's, to some degree, it's stripping away the guilt
Right.
associated
There's
with
tons
insomnia.
of guilt. Yeah.
Absolutely.
Guilt's rampant, right?
It's by far.
So I tell patients I'm an anti-guilt guy,
Okay.
right? Because the same like obstructive sleep apnea, just because someone has it, it's not their fault,
Right.
right? Insomnia frequently is biologic once we get through all these things we've already talked about,
Right.
So there's that element of getting people in a place where their biology can be normal.
Yeah.
then we can uncover their true biology.
I mean, you just say it over and over again that we have to deal with stuff well before. Sleep is the tail end, it's like the end of the day, but we have to lots of stuff that we need to do in advance before we get to the point where we're stuck. A lot of us, because we have 15 minutes with the patient, I'll put them on sleep and hopefully it'll help their pain, or hopefully it'll help their depression, hopefully, so that I'm trying to get to, killing three birds with one stone type stuff.
And it's difficult. So we had a talk I gave for years called "It's the Common Final Pathway."
Yeah, it is.
And if you look at sleep, every disease state, when it becomes chronic, has a sleep disruption component. Whether it's heart failure, chronic obstructive lung disease, GI, and so
psychiatric disorders.
So but if you just treat the sleep piece, you're not going to fix everything, right? But it has to be part of the plan, right? And you said this very early on, which is smart and always interesting to me. It can be a very interesting diagnostic. For instance, when someone would have an asthma exacerbation, right?
Yes.
My trick in the morning when I'd see them in the hospital was not to ask them about their asthma, but to ask them how they slept that night. And when they slept all night, you knew you were winning. Right? Their asthma was quieting down because they weren't getting up at night to breathe. Right. Same with COPD. So
heart failure, same way.
Exactly. But it's getting people to have that biological insight to see that as valuable, because our colleagues are so busy. They're so smart and well trained, but they're so busy that these kind of little things are difficult to incorporate.
It is, and it makes it. Unfortunately, it parlays into so many different things, and we're chasing. I mean, what you hear me saying is I'm chasing my tail a lot, and it's because I'm not starting at the beginning, like the song says.
So I think that dovetails beautifully into my next question, which is, many of our young patients, especially, we're going to talk about energy drinks here. So many of our young patients that we're seeing come to us dealing with depression, anxiety, bipolar disorder, that's also affecting their sleep. They are heavily reliant on caffeinated beverages and nicotine as well to get them through their days, school, work, whatever it is. What do you think this is attributed to? How can we convince people to sort of give up on that crutch, which a lot of these patients can feel like this is the only thing that's helping me function. If I give this up, what else do I have left? Can give us some hope with that. Help us out.
But it's difficult, and my approach probably isn't a purist approach, which is that. But let's not let perfection get in the way of progress.
Sure, yes. So, perfection's the enemy of good enough, right? Yeah.
So if we have a conversation about what it might look like if you just made some effort, it doesn't have to be perfect, at better sleep, choosing sleep is a better habit. And then let's have a goal for diminishing the amount of caffeine dependency you have. At the end of the day, all those things are just caffeine delivery systems. Right?
Absolutely.
And so let's choose some. You can take them, but let's only use this many doses of caffeine, say, in the morning. Or what's the reason? Are you using caffeine because you're working nights? We do need to understand their lives,
the context,
right?
And I actually find it fascinating. That, to me, is really interesting. Part of what we do is understanding where people are coming at in their life. If you work nights, and I think the other part, the anti-guilt thing, there's a real interesting book called The God of the Mundane, is to, it's to sort of acknowledge each other as fellow citizens of our community, fellow human beings, and acknowledge that people that are working really hard to get through life are heroic. Right? You don't just have to throw a football or hit a baseball to be heroes. Somebody who is a young parent and they're working 3 jobs to put food on the table. And I mean, they're heroes to me. And so acknowledging that to them and saying, hey, look, we're with you. Let's work together.
You're not relying on these things because you are weak and
exactly. And so let's have a goal, right?
Yourself. Yeah, absolutely.
But to do it in a space that's not guilt driven, but is positive, I think that can help folks a lot. We do see it help folks. Plus, sometimes people need the ability to not feel guilty.
Absolutely.
There's been a lot of tears shed in our office when we tell people that, and they break down. And
the tension is so
they're carrying this burden with them. And if you relieve that burden, I mean, we are called to practice medicine and that means ministering to people where they are.
Yeah.
You know,
Right.
and it isn't all about giving them just antibiotics.
Your Catholicism is coming through. Good
No,
job.
it's important. I
Right?
mean, you have to.
Well, that's what St. Paul says, right?
Right.
You meet people where they are.
It is.
And in healthcare, I think the more we can do that, and God knows I'm not perfect, but the more we try to do that, the better people tend to do.
Absolutely.
And they respond to it.
Yeah. Shame
Yeah,
is
it
a
is.
terrible motivator.
Yeah.
It does not produce long-lasting results. It does not
Zero.
empower people to feel like they have any agency or control over themselves.
Right.
I love that approach.
One of my dear mentor friends, we have a theory called we'll call it the bag of stuff. And everybody carries their bag of stuff, right?
Mhm, yes.
But healthy people, they empty the bag every day,
Yeah.
right? And the people,
Right.
like, for instance, that you're caring for, they frequently can't, no one's helped them
Yeah.
empty it,
Right.
right? And until you get rid of that stuff, it really comes out with sleep.
Yeah.
Because
Yeah.
what happens at night, everything's right.
Right.
We say everything
right
gets
there
worse
for
at
me.
night.
Yeah,
It's just
Yeah,
like,
it is.
and so if you can get that stuff off the table, this speaks again to the worry journal. And we had one fellow who came in for sleep, and we were interviewing him. Very interesting gentleman, late middle age, and he'd been talking to our PhD, who's a very lovely guy, for probably 45 minutes to an hour. And we walked in and we start shooting the breeze a little bit. And, sometimes just clinically you're going, okay, I just kind of went for it. He said, when did this all start? Anyway, he just exploded and had his cathartic episode where he described how as a young person, he'd been beaten with a 2x4. And I don't even know that he really realized he was, but
Traumatized.
his
Yeah.
wife was just there with, she, I think, had some knowledge of it, but that was it.
Yeah.
Once that all kind
Absolutely.
of got out, and then we said, like, okay, we're not there. We don't hold ourselves out as therapists. We're not therapists.
Neither
When
are we.
when those things are uncovered, we help people get where they need to go.
Absolutely.
But the point is, it got the conversation started.
Right.
So anyway, that's part, I think, of what we.
Yeah.
I'm still a silly guy. I think Dr. Tadros is too.
Very-
I still have the same one degree of wonder and excitement
are.
of being a doctor that I ever had when I was.
You're
20.
you're very bright-eyed. People should meet you. You're very bright-eyed. As you talk, your eyes get bigger and bigger and bigger.
But I think I love that
It is.
it's a
can't-
privilege to
it's-
do this.
It is. It is a privilege. You're exactly right.
And one of
what
our-
what a blessing. You're absolutely correct.
And one of my dear colleagues, who's not a primary care physician, but just a little older than we are, but we are out, and he has said something so smart. He goes, I guess I still believe that that our city and our country made an investment in us to be physicians, and I have a moral obligation to practice as long as I can. Now he doesn't want to go,
Right.
but
Right.
to provide the service because they gave me so much in investing in my education
Right.
that this isn't just a benign transaction; it's a
Right.
moral transaction.
Sure.
I'm like, that is really deep.
It's beautiful.
It is.
Yeah.
And he's a beautiful doctor.
Yeah.
But I mean, I was like, that is heavy duty discussion.
It's the antithesis of burnout, of how people feel in burnout, that they give, and they don't feel anything in return, and that's burnout. So that's how you not to burn out. Obviously, this is exactly right.
I think that's probably as much as we have time for today. But it's been so wonderful and lovely to talk to you, Dr.
Well, thank
Ojile.
you. My privilege.
Thank you so much for joining us. I mean, we could keep continuing this conversation
And
for
we will.
forever.
I'm
and we
gonna.
will.
I'm
Yeah,
arm
please.
twisting. He knows already.
I'd be happy to do this.
I'm
Yeah.
arm twisting sometime in the future to talk about this and any other topic that you enjoyed talking about that you want to get off your. Yeah, that will be your journal. Will be your
You'll be my
Yeah,
worry
thoughts,
absolutely. We'll be
thoughts
your
of the
worry
day.
journal,
Well,
something like
it's
that.
it's like all about bringing our community better health. I
Yeah.
realize that your
Absolutely.
podcast has a reach bigger than our community, but these are problems that people have all over our country.
Yep.
Absolutely.
Right?
It's universal.
Absolutely, and that's totally, the purpose of this show in general is just to bring light to some of these issues and ultimately bring hope to patients. That there are very caring doctors like you and like Dr. Tadros, working on these things, and that there are resources and people can take charge and ownership of having a quality of life that gives life and allows us to share it forward, just like you're talking about.
We want patients to be curious and inquisitive about their own health and just about the medical system and anything else that they're interested in. It's like hopefully we are. We're still hopefully inquisitive and curious.
Well, I'm hopeful because I think the young doctors are smarter than ever.
Yeah.
Young people are smarter than ever. And we have an obligation to give them the ability to be joyful in caring for patients.
Yeah. Big deal.
We sometimes tell our office staff, because, it's hard to be office staff at a doctor's office.
Front line.
I go, look, one, the patients aren't the enemy. And two, our main mantra is, you have to love them all. Absolutely. You don't have to like them, right? Because it's just like sometimes
like
even
your
people that you
children.
love,
Like
you get a little irritated, but you still love them, right? So our
Absolutely.
patients,
it's a labor of love, completely.
But sometimes we're not perfect. It's more difficult than others.
Absolutely.
They're called to test. Thank you.
Thank you.
Thank you so much.
Thank you, Seth.
Guys, it's
Thank you,
been
Joe.
another great episode of the Not Your Doc podcast. If you have any feedback or questions for us, of course, you can reach out to us on our website at notyourdoc.com. That's going to be forthcoming, and we will see y'all next time. Thanks so much for hanging out with us.
This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.